Hello students. So this is a part of our 90-day university pre-final mastery program. And in this class, we are going to discuss gastrointestinal pathology. We are going to discuss a few frequently asked questions in your exams. And at the end, we'll be discussing a few multiple choice questions also. So this consists of rapid revision of all topics along with volatile topics for quick revision. In Auricle, we are having recorded classes, live classes, practical sessions, exam modules, and also hard copy book sets. The recorded classes are very helpful for flexible learning and convenient revision. The live classes, we cover in-depth topics, and interactive learning is also there with MCQs, Viva, and more. Express exam module covers the syllabus in just 20 hours and it has all important questions, all frequently asked questions there in your exams, and also answer writing skills will be discussed. There is a one-to-one doubt clearing session. Hard copy note set are also available for all subjects. There is a question bank with varying level of difficulty from beginner to expert level for your Proff exams to NEET PG level questions. Practical sessions are also there, which facilitate hands-on experience, which simulate the real practical scenario. These are certain subscription plans, which you can visit the website and learn more about. Today, we'll be discussing long cases, short answer questions in the gastrointestinal pathology. So the first long essay question, which we're going to discuss is this one. We'll just read through the case. This is a 70-year-old male with loss of appetite and weight loss for a period of 6 months. So loss of appetite and weight loss are very classic. Anorexia or loss of appetite is a classic symptom of gastric carcinoma. Clinical findings: there is a palpable mass in the epigastric region and endoscopy shows ulceroproliferative growth in the lesser curvature. Always remember, this is the anatomy of stomach. This is the esophagus and this is the stomach, right? So there are two curvatures. This is the lesser curvature and this one is the greater curvature. So whenever most frequently carcinomas involve the lesser curvature and peptic ulcers involve the greater curvature. It's not a hard and fast rule, but just remember these are certain clues which can help you clinch the diagnosis. So there is an ulceroproliferative growth, makes it very easy to diagnose. So this is a gastric carcinoma over here. Due to an ulceroproliferative growth which they have given. Even though ulceroproliferative growth is not given, we know there is loss of appetite and weight loss for a long period of time. So this is a gradually increasing condition, and of course there is a palpable mass in the epigastric region. So everything points towards a gastric carcinoma. What are the etiopathogenesis of gastric carcinoma? We know there is a bacterial cause of gastric carcinoma, so which is H. pylori. We know H. pylori is the bacteria which causes gastric carcinoma. Apart from gastric carcinoma, what are all the conditions H. pylori causes? We know there are a bunch of conditions which H. pylori causes. Of course, we know one is gastric carcinoma of stomach or gastric carcinoma. Apart from that, it is going to cause peptic ulcer disease. It can also cause chronic gastritis and can cause mild lymphomas. So H. pylori is a very important cause of carcinoma stomach. Then we have nitrate-rich foods, which can lead to carcinoma stomach. So nitrate-rich food can lead to carcinoma stomach. Apart from this, we have smoking as a risk factor. Smoking, alcohol consumption is a risk factor of carcinoma stomach. Okay, so these are all main factors and main things which we have to remember. And there is another condition which is atrophic gastritis. Atrophic gastritis can be caused by an autoimmune condition. This autoimmune condition is known as pernicious anemia. Okay, pernicious anemia. As the name says, there is anemia in it. So some kind of anemia is going to happen. Okay, so pernicious anemia. Pernicious anemia is due to the autoimmune destruction of parietal cells which are present in the stomach. These parietal cells have a very important function, which is the production of an intrinsic factor. Why is this intrinsic factor important? Okay, intrinsic factor is important in the absorption of vitamin B12. Okay, so this vitamin B12 intrinsic factor, if intrinsic factor is destroyed, vitamin B12 absorption is not going to happen, right? If we do not have vitamin B12 absorption, then we're going to have deficiency of vitamin B12. What anemia is going to be caused with vitamin B12 deficiency? It is going to be megaloblastic anemia. Okay, so hence the name anemia for pernicious anemia. So it is a B12 deficiency, and it can also cause gastric carcinoma because there is atrophic gastritis which can be caused by this condition. So it's all in the pathogenesis. So we know a few conditions which can cause gastric carcinoma now: H. pylori infection, diet, that is nitrate rich diet, and certain genetics. Genetic mutations can lead to the gastric carcinoma. For example, there is a very specific mutation, CDH1 mutation, which can lead to hereditary gastric carcinoma. Okay, hereditary gastric carcinoma, and there is a very specific type of carcinoma which this can result in, that is diffuse type of gastric carcinoma. CDH1 can produce a protein which is known as E-cadherin. Okay, and this E-cadherin is responsible for holding up cells together because this is a cell adhesion molecule. This is a cell adhesion molecule. What does cell adhesion molecule do? They try and hold up cells together to each other. So with the CDH mutation, what is going to happen? This E-cadherin protein is not going to be produced. And if this is not going to be produced, you will not have any E-cadherin protein in between these cells. As a result of this, all the cells are going to be separate, singly scattered. Okay, so this is a diffuse type of carcinoma where all cells will be singly scattered, CDH1 mutation, and this is a very aggressive type of tumor because this can easily spread via lymphatics and blood vessels. So this is the genetic mutation which is the cause of gastric carcinoma. So genetics we have seen here, leading to mutations and abnormal cellular growth. Morphology, when we come to morphology, there is 4 specific, grossly we have to remember 4 morphologic features which is very specific to gastric carcinoma. So before that, we will just quickly review the histology. What do we have here? This is the stomach. Okay, this is the place, this is the lumen where food resides, right? This is where food is. So this is the first part over here. This is the mucosa adjacent to the lumen. Okay, and below the mucosa, what do we have here? Below the mucosa, submucosa. Sub is below, so submucosa we have here. And after that, we have muscularis. And then at last, we have serosa. Okay, so the morphologic features which we have to remember is number 1, ulcerative or ulceroproliferative. Okay, this is exophytic. Ulcerative is going to be ulcer. So you are going to have a crater-like depth appearance over here. So this is ulcerative. Second one is exophytic. As the name says exophytic, there has to be some protrusion outside. So there is an exophytic mass. So this is exophytic. The third one is infiltrative. In infiltrative, usually it's going to go inside the mucosa. Okay, so from the mucosa, it's going to go inside either to the mucosa, submucosa, or the muscularis. So this is infiltrative lesion. It's going to invade the other layers. Fourth one is combined. Okay, it can be either ulcerative, exophytic together, infiltrative, exophytic together. So any of these combinations. So this is the gross appearance. Microscopically, you have to remember 2 important subtypes. One is intestinal subtype. Okay, I have mentioned that H. pylori causes gastric carcinoma and also atrophic gastritis causes gastric carcinoma. Both of these conditions will lead to a intermediate condition which is known as intestinal metaplasia. And this intestinal metaplasia will finally lead to intestinal type carcinoma. Okay, so we know there is a metaplasia from our general pathology. Also, we know there is a metaplasia even in squamous cell carcinoma. First of all, the bronchial epithelium will get converted in the squamous cell carcinoma of lung. The bronchial epithelium will get converted into a squamous epithelium. The bronchial columnar epithelium will get converted into a squamous epithelium, and that will undergo dysplastic changes and ultimately form carcinoma with continuous irritation. So this is what happens here also. There's an intestinal metaplasia, and this metaplasia can further lead to intestinal type of carcinoma. So this is very common with H. pylori infection and also atrophic gastritis. Okay, so this is the method by which there is this intestinal carcinoma. Another type also we saw diffuse type of carcinoma. Diffuse type of carcinoma is common with CDH1 mutation, which is associated with E-cadherin protein. Okay, and this has a signature type of morphology. You will see cells pushed to one side by mucin. Okay, so this is called signature type of morphology is common in diffuse type of gastric carcinoma. So this is the morphology, gross and microscopy in gastric carcinoma. Now let's move on to the short answer questions. First short answer question we are going to discuss is Mallory-Weiss syndrome. Mallory-Weiss syndrome is nothing but longitudinal mucosal lacerations at the gastroesophageal junction. So we know that this is the esophagus and this is the stomach. Okay, and through here there is the duodenum. It goes on into the small intestine, right? So there is a sphincter over here. Okay, this is the gastroesophageal junction. In between the stomach and esophagus is the gastroesophageal junction, and there's the gastroesophageal sphincter also over here. So what happens when there is forceful vomiting? When there is forceful vomiting, because of so much of pressure, there are lots of lacerations in the gastroesophageal junction. There is lots of mucosal laceration, and this is known as Mallory-Weiss syndrome. And this would, how do you know that there is laceration or tear near the gastroesophageal junction? Because the patient will have blood-tinged vomitus. And the patient vomits, the patient will have blood in the vomit. Because of forceful vomiting, there is tear here. So this is Mallory-Weiss syndrome. You can see there are lacerations over here. And because of this forceful vomit, you will have when the patient vomits, you're going to have blood in the vomit. So these are longitudinal mucous membrane tears, but most important thing is these are limited to the mucosa and submucosa. So you will not see these in the muscularis or in the serosa. Okay, so limited to the mucosa and the submucosa. Similarly, there is another condition which is known as Boerhaave syndrome. In Boerhaave syndrome, the tear is transmural. That is, you're going to have the tear throughout the layers. Even the mucous, the muscularis and the serosa is going to be involved in Boerhaave syndrome. And this is not exactly in the gastroesophageal junction, but in the distal esophagus. Okay, in the distal esophagus. So these are the two conditions which you have to remember. Both of these are associated with vomiting, and after alcohol also this can be seen. Boerhaave syndrome and Mallory-Weiss tear. Okay. So next short answer question which we are going to discuss is intussusception. This is a condition where part of the intestine slides into adjacent part, causing an obstruction. So what happens? Usually this occurs in the ileocecal junction. We know that in the large intestine, we have the small intestine here, and the small intestine goes and transforms into the large intestine, right? And then we have the rectum and the. So This is the ileocecal junction where our small intestine gets transformed into the large intestine. Okay, and this is where we have the appendix also. This is in the right side of the, this is in the right side. So this is the ileocecal junction. So what happens is sometimes this ileum, because the cecum is significantly larger when compared to the ileum goes into the cecum and gets stuck inside the cecum. So this is what intussusception is. So in this case, what will happen? There is no proper bowel. So you're going to have obstruction. The food is going to get stuck here, resulting in intestinal obstruction. So this is linked to viral infection. This can be caused due to viral infection or any other intestinal masses also. So this is the intussusception. You can see here normal intestine, this is open. The tract is open, so food can go. But in intussusception, the bowel has come into another bowel loop. So the lumen here is blocked. This will lead to intestinal obstruction in children. Similarly, there is something else known as volvulus. Okay, volvulus is nothing but twisting of the bowel loops. This is also common in children. So intussusception, bowel usually in the ileocecal junction, and volvulus twisting of the bowel loops. Also in children, we have another condition also which will result in intestinal obstruction. We read about it. It is Meckel's diverticulum. Meckel's diverticulum almost always occurs in the ileum. What is Meckel's diverticulum? Diverticulum, as we know, diverticulum is an outpouching, and Meckel's diverticulum is a true diverticulum. And why is it called true diverticulum? Because it has all the 4 layers of the bowel wall. As we said, it has mucosa, it has submucosa, it has muscularis, and it has all the layers when it is outpouching. So that is a true diverticulum. Whenever only few layers are there, it is known as a false diverticulum. So what is the most common complication of Meckel's diverticulum? It's going to be bleeding, and this diverticulum can also cause intestinal obstruction. So these are the 3 causes of intestinal obstruction in children. Intussusception, where a bowel goes into another bowel causing obstruction. And you have volvulus, twisting of the bowel. Volvulus can also result in intestinal obstruction. Meckel's diverticulum can also result in intestinal obstruction. What will you see in the Meckel's diverticulum? You're going to see ectopic mucosa. Okay, it occurs in the ileum, right? But what will you see in the Meckel's diverticulum? You can see pancreatic mucosa, or you can see gastric mucosa. Okay, so this is what happens in the Meckel's diverticulum. Causes of, this is what intussusception is, and all the other causes of intestinal obstruction in children. And then next short answer question which we are going to discuss is the pseudo polyp. Pseudo polyp, as the name says, it is not a true polyp, it is a pseudo polyp, right? So this is a non-neoplastic polypoidal lesion seen in inflammatory bowel diseases due to regenerative mucosal proliferation. First of all, what is a true polyp? A true polyp is a protrusion of the, there is intestinal is an intestine, and there is mucosa, there is glands in the mucosa. Yes, there are submucosa, there are muscles in the muscularis and all these things. So a polyp is just a protrusion of all these tissues outside. Okay, whereas in the pseudo polyp, you will not see any glands, you will not see any smooth muscles, you will not see any muscularis, nothing you will see. What you will see is just mucin and inflammatory cells. Okay, these are not a reflection of a polyp, these are not reflection of the true tissue, not a polypoid, but these are just something which is stuck over the bowel, which looks like a polyp. So that is a pseudopolyp. So when will you get a pseudopolyp? You will get a pseudopolyp in inflammatory bowel diseases, most commonly in ulcerative colitis. Ulcerative colitis, you will have pseudopolyps most commonly. And what are the other inflammatory bowel diseases? There was ulcerative colitis and Crohn's disease, right? So I am going to quickly review a few differences after seeing this pseudopolyp. So this is the pseudopolyp. 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 This is the Okay, when the microscopy is done, you can see there are no glands here, nothing like that, just inflammatory cells. Yeah, and fibrin. So this is what pseudopolyp is. This is a case of ulcerative colitis where you can see pseudopolyp. It looks like something is protruding, it looks like a polyp, but it does not have any characteristics of the origin tissue. So this is what pseudopolyp is. This is again a image of true polyp. Okay, this is a true polyp. This is a true polyp. And here you can see that there are glands, there are smooth muscles. Okay, this is a type of a polyp. And you can see all these things are there here. So this is a true polyp and this has none of those things. This is a pseudopolyp. Okay. So now I'll just quickly review a few differences between ulcerative colitis and Crohn's disease. Okay. In ulcerative colitis, usually first thing which you have to remember is ulcerative colitis is usually involves the rectum. Okay. And it is also known as a pancolitis. So it usually involves the whole intestine. Okay. It continuously involves most of the rectum, sigmoid colon. Okay. These are the places where ulcerative colitis is affected. Rectum, sigmoid colon, and somewhat transverse colon and ascending colon. So this is the pattern of involvement of ulcerative colitis. But Crohn's disease is not like that. Crohn's disease actually can involve somewhere here, then here, and then it can have oral lesions. Okay, it can have mucosal lesions. It can involve the small intestine. So it does not have a continuous pattern of involvement. So this is known as skip lesions. So they will have lesions here, and this area will be free, and this area will be again involved. So these are known as skip lesions in Crohn's disease. Okay. Next thing which you have to remember is ulcerative colitis usually does not have transmural involvement. Okay. No transmural involvement. And because it does not have transmural involvement, there are polyp formation. Because see, transmural involvement means it's going to involve all the 4 layers and through involvement. So polyps will not be formed when there is a through involvement. Polyps will be formed only when there is a superficial involvement. So polyps are going to get formed and stuck on the superficial mucosa. When there is through involvement, what is going to be formed? Fistula will be formed. Fistulas will be formed in Crohn's disease because there is a through involvement in Crohn's disease. Other thing which you have to remember is granulomas will be not very common in ulcerative colitis. So not very common granulomas, whereas granulomas will be common in Crohn's disease. Crohn's disease, you will have granulomas. Okay. And what are the complications? We know fistulas are formed, so perforation will be there. Perforation can be there in ulcerative colitis also in later stages. But there is another important complication where the bowel is very much dilated and there is a megacolon. Okay, this is known as toxic megacolon. Toxic megacolon is a complication of ulcerative colitis. Okay, and Crohn's disease also will have fissures and fistulas. Perforation can be a complication of Crohn's disease. So will malignancy occur in ulcerative colitis and Crohn's disease? Will it occur in only ulcerative colitis or Crohn's? Actually, malignancy can occur in both. Malignancy, that is colonic malignancy, can occur in both ulcerative colitis and Crohn's disease. So both of it can cause ulcerative colitis and Crohn's disease, but slightly increased in ulcerative colitis since this is a lesion which has pancolitis compared to Crohn's disease. So these are a few differentiating features. Now let's move on and discuss another short answer question, which is amoebic colitis. Amoebic colitis is caused by Entamoeba histolytica infection. This is a parasite And usually the presenting symptoms are going to be dysentery, abdominal pain, and there are, in histopathology, you will see ulcerations in the colon. That too, very specifically, you will see flask-shaped ulcers. You will see flask-shaped ulcers. Okay, I've shown an image here. You can see here that these are the flask-shaped ulcers of entamoeba. Okay, and these are the organisms. Okay, these are the organisms. A few organisms you can see have ingested these red blood cells. You can see there are a few red blood cells inside the lumen of these organisms. So these are entamoeba organisms, and you can see that they have ingested a few red blood cells. You can see this pink material inside these. So this is a feature of entamoeba, and this is known as erythrophagocytosis. We know red blood cells are known as erythrocytes, right? So erythrophagocytosis. Flask-shaped ulcers, okay, entamoeba organisms, erythrophagocytosis, and then you can see here, this is a gross image of this. You can see there is a pus-like material, okay. So this is what is known as anchovy sauce type fluid, which comes out. Anchovy sauce like appearance, which can be seen in gross. So these are the few features which I have to remember. These are flask-shaped ulcers. Okay. Next is another question, which is again a short answer question, which is pseudomembranous enterocolitis. As the name says, there is colitis, so there is inflammation of the colon. So this is associated with antibiotic use and leading to Clostridium difficile infection and pseudomembrane formation. So now there is increased antibiotic use. But Clostridium difficile itself is a bacteria. So how does it work? Why does this infection come? What happens when there is excess use of antibiotics? These antibiotics tend to destroy the normal flora. Normal flora. We know that intestine has enterobacteria. Entero is intestine, so it's going to have lots of enterobacterium, which consists the normal flora of the intestine. When there is excess antibiotic use, what is going to happen? These normal flora are also going to be destroyed in the process. So because of that, the normal flora is being destroyed, and it leads space for colonization by Clostridium difficile. Okay, so this Clostridium difficile is fairly resistant to most of the antibiotics. So there are very specific antibiotics which can be used against Clostridium difficile. For example, vancomycin is very effective against Clostridium difficile. You will be reading in your pharmacology about vancomycin. So this is one thing. So what will happen if there is lots of Clostridium difficile infection? You are going to have pseudomembrane formation. Okay, there is a pseudomembrane formation, and the patient will have diarrhea. Okay, there is a pseudomembrane formation. The pseudomembrane will not facilitate any absorption, so the patient is going to present with diarrhea. So how does this pseudomembrane look like? In endoscopy, you can see that these are all membrane-like pseudomembranes. Okay, these are all these pseudomembranes, white colored patches. If you want to see in histology, this is what the pseudomembrane looks like. It is also known as a volcano-like appearance. As you can see that this is just coming out, abruptly coming out from the epithelium over there. So this is a volcano-like appearance which you can see in pseudomembranous colitis. What is the organism which is causing pseudomembranous colitis? It is Clostridium difficile infection. Okay, so this is how it looks in endoscopy. This is how it looks in microscopy. Next short answer question which we are going to discuss is villus adenomas. Villus adenomas Adenoma, as the name says, villus adenomas are just a type of adenomatous polyps. So adenomatous polyps have very increased risk of malignancy. Okay. So what are the type of adenomas? We have adenomatous polyps are of three major types. So adenomas are of three major types. We have tubular adenomas, tubulovillous adenoma, and villous adenoma. Tubular adenomas, as you can see here, have tube-shaped glands. Okay. Villi, as you know, in the intestine, it's going to be like this. And the glands are going to be like this. Tubulovillous, tube-shaped glands, as well as villi. Villous adenoma, predominantly finger-like villous projection. So these are the three types of adenoma. So now, which has the most highest malignant potential among these three? Which will go into become carcinoma? Most frequently, it's going to be villous adenoma. Villous adenoma has the most potential of becoming into malignancy, followed by tubulovillous and then tubular adenoma. So this is the thing which you have to remember. Then in this context, I am going to just review a few other colonic polyps. First of all, hamatomatous polyps. Hamatomatous polyps. Hamatoma means there is some foreign tissue or some tissue which does not belong to the original area which is present. So hamatomatous polyps are juvenile polyps and Creutzfeldt's polyps. In Creutzfeldt's polyps, there is going to be many smooth muscles which we will be seeing, and we have PTHS, P10 associated hematomatous polyposis syndrome, and then there is hematomatous polyposis syndromes and Cronfite Canada syndromes. So these are hematomatous polyps. These also can convert into malignancy, but they have low risk of malignancy. Okay, hematomatous polyps have low risk of malignancy. Inflammatory polyps have pseudopolyp, as we saw, associated with ulcerative colitis. We had pseudopolyp, and there is a benign lymphoid polyp. Usually, these polyps have very low risk of malignancy. Now, neoplastic polyps are what are very important because they are the ones which are going to get transferred into malignant conditions. So, these are the ones which you have to look out for. Adenoma, we already saw. We had tubulovillous, and villous adenomas. Okay. And then familial adenomatous polyposis associated conditions. Familial adenomatous polyposis is again associated with adenomatous polyps. Miscellaneous, we are going to have hyperplastic polyps. So this also has very low tendency, in fact, no tendency to transfer into malignancy. Okay, so this is for villous adenomas. Now we are going to discuss the most important familial polyposis syndrome. This is an inherent condition, and how is this inherent? This is usually inherited as an autosomal dominant condition. Okay. Familial polyposis syndrome is associated with autosomal dominant syndrome. This is also known as familial adenomatous polyposis syndrome. Okay. So this has numerous, in fact, more than 100 polyps can be identified, often leading to colorectal carcinoma if untreated. Okay. This is caused by mutations in the APC gene, which is present in chromosome 5. So these are a few genetics associated with familial adenomatous polyposis syndrome. Okay, this is an image from a patient of familial adenomatous polyposis syndrome. You can see how many small polyps are there. There are just so many polyps. So this is when you have a patient with so many polyps, you have to think of familial adenomatous polyposis syndrome. And when a patient of familial adenomatous polyposis syndrome is there, they're going to have an adenoma like this. Okay, this here is a tubular adenoma because you can see mostly there are round glands over here and you do not see much of villi over here. So this is a tubular adenoma. So these patients almost always develop colonic carcinoma. Okay, almost always, 100% of the cases, they are going to develop carcinoma colon. So in these patients, what will you do as a treatment? We're going to do prophylactic colectomy. Okay, because you know that this patient is going to develop carcinoma of colon? 100%. Right. So these patients are eligible for a prophylactic colectomy. Now we're going to discuss another question, which is after polar staging of colon cancer. First of all, we have to again revise the layers of the colon for discussing the staging system. We know that there is mucosa over here. These are the glands. This is the mucosa. Below the mucosa, you are going to have submucosa, and then you are going to have muscularis, and then you are going to have serosa. Okay. Now there are two important staging systems which are there for colonic carcinoma. One is Duke staging system, which is most widely used, and then there is an Astor polar staging system of colonic carcinoma. So Duke staging system is divided into 4: Dukes A, B, C, and D. It is actually very important. Very easy also to remember. Dukes A is invasion into but not through the bowel wall. Okay. What do they mean by Duke A? That means there is invasion. There is a carcinoma over here, and this carcinoma is invading somewhere up till muscularis, but it's not going into the serosa. That is what is Dukes A. Okay. Dukes A, invasion is there. It is going inside, but not through the serosa. So that is what is Dukes A. Okay. Dukes B is invasion through the bowel wall. Dukes B is there is a carcinoma here. It is invading through the bowel wall. It's going outside the serosa, but still lymph nodes are free. So this is what Dukes B is. Lymph node has not been involved yet. So that is Dukes B. What is Dukes C? Dukes C is lymph nodes have been involved. Okay, does not matter if the mucosa is fully involved or not involved. Lymph nodes have been involved, so it is Duke C. Okay. What is Duke D? Duke D is nothing but D for distant metastasis. Okay, D for distant metastasis. Very easy. Duke A, through the invasion is there, but not through the serosa. Duke B, invasion is there through the serosa, but lymph nodes are free. Duke C, lymph nodes are involved. Duke D for distant metastasis. Okay, this is Duke staging system. The next one is modified Astor polar staging system. Now again, I'm going to draw the same diagram. Okay. This is the mucosa, submucosa, muscularis, and then we have the serosa. Okay. So stage A. Astor polar stage A is limited to the mucosa. Tumor is just here. Tumor is not going anywhere else. Tumor is just in the mucosa. Okay. And then we have stage B1. Stage B1 is extending into the muscularis propria, but not going in. It's just touching the muscularis propria, but not going beyond that. Okay. And then nodes not involved. Of course, nodes not involved. B2 is also penetrating into the muscularis propria, but B2 is penetrating through the muscularis propria, okay, but it is not going to penetrating. Nodes are not involved in this also. Okay, this is B2, penetrating inside the muscularis propria. So B1 is just touching the muscularis propria. So that you have to say present in the muscularis propria, but not penetrating through the muscularis propria. So I'm going to just add a small dimension to the muscularis propria to understand it's going to be penetrating or not. So this here is the muscularis propria now. Okay, this is the muscularis propria. So both of these B1 and B2 nodes involved or not involved, nodes not involved. Now we are going to see C1 and C2. It's the same thing. B1 is the same as B1 and B2. What was B1? B1 was just touching the muscularis propria but not penetrating through it. So C1 is also the same. Tumor is just touching the muscularis propria but not penetrating to it. What is C2? See, it is penetrating through the muscularis propria here. But the only difference here is nodes are involved. Nodes are involved. That is the only difference between these two. D here also is distant spread. So very easy. We'll just revise our dukes here. A is anywhere into the muscularis propria, but not through and through in the serosa. Okay, not through the serosa. A is not through the serosa. B is through the serosa, lymph node free. C is lymph node involved. C somehow looks like L. So you can say C is lymph node involved. D is distant metastasis. Now, modified aster. A, only mucosa. B1, B2. B1, just touching the muscularis. B2, penetrating the muscularis, but nodes not involved in B. Okay. C, again you see C nodes involved. C like lymph node involved in C also. Similarly, nodes involved in C also. D again, distant metastasis. So this is the staging system of colonic carcinoma, which they have asked. Okay, now let's move on to discuss a few MCQ questions. This MCQ, 55-year-old man presents with fatigue and iron deficiency anemia. Colonoscopy reveals a large exophytic mass in the ascending colon. Okay, there is a mass in the ascending colon. Which molecular alteration is most commonly associated with this type of tumor? Okay, first of all, I'm going to, for this, we have to discuss right side and left side colonic carcinomas. I'm going to give you a quick overview. Okay, we know there is the ileum, and from the ileum we have the cecum. Okay, this is the ileocecal junction. This is the ascending colon, transverse colon, descending colon, sigmoid colon. Right, rectum. So this is the cecum over here. This is the sigmoid colon, rectum, and here somewhere we are going to have the appendix. Okay, so cecum, ascending colon, transverse colon, descending colon, sigmoid colon, and rectum. Okay, so we know that this is the right side and this is the left side. So there are a few features which differentiate between right side and left sided colonic carcinoma. So large exophytic mass presenting in the ascending colon naturally makes it a right side associated tumor. Okay. So one most important thing which you have to remember is right-sided tumor present with iron deficiency anemia, left-sided tumor mostly present with obstruction. Okay, that is one thing. Second thing is, usually right-sided tumors are associated with microsatellite instability and left-sided tumor are associated with APC gene mutation or the KRAS gene mutation. There are two pathways which are associated with these mutations. I think we'll just discuss it very quickly. Okay. So this is known as the adenoma carcinoma sequence. This is also a question. I'll be discussing it soon. Adenoma carcinoma sequence. Okay. In the adenoma carcinoma sequence, what we are going to have is, first of all, there is a tubular adenoma. Okay, this is usually what happens in the left side of the colon. We are going to have an adenoma, and the adenoma is due to an APC mutation, and then you are going to have a KRAS mutation, which is going to convert the tumor into a carcinoma. So, okay, this is just a quick overview I'm giving. So, this is the left-sided pathway, and in the right-sided pathway, we have a serrated lesion. Okay, usually can be caused by any mutation like BRAF or something like that. And then this can be converted into a serrated or infiltrative kind of carcinoma. And for this, we have certain mutations, which is MLH1, MSH, and PMS. So these are the mutations which can be present. So these three proteins are known as microsatellite instability, stability. These are the proteins which are required for microsatellite stability. So when there are mutations in these, there is going to be microsatellite instability. So this is what happens in the right side of the column. Okay. So for this, the answer is microsatellite instability. If you are asked a left-sided lesion, then the answer would be KRAS mutation. Okay, most commonly, because this is the most common, even though everything can happen in left side. So this is the for left side, this is for right side. I'll be discussing in further classes on how to more differentiate right and left side with colonic carcinomas based on histology and other things. So moving on to the next question. A 45-year-old male undergoes routine colonoscopy that reveals multiple adenomatous polyps throughout the colon. Genetic testing shows mutation in the APC gene. Which syndrome is he most likely to have? Very easy, this we just discussed. He has familial adenomatous polyposis syndrome. Okay. Moving on to the next one. A 38-year-old female presents with abdominal pain and diarrhea. Imaging reveals transmural inflammation in the ileum with skip lesions. Two important words, transmural, skip lesions. Both will go hand in hand with Crohn's disease. We already discussed this. So that is all. We discussed a few very important questions, and in the future classes, we are going to discuss a few more questions in relation to gastrointestinal pathology. So that is all for today's class. Thank you very much.